And I have a less sexy topic, obviously, and the question is, why do we talk about that anyway? Now, this is a well-healed compression anastomosis, and perhaps we could put the lights down because there are a lot more of these pictures to follow, and it's very hard to see where the anastomosis actually is. And before we go to the anastomosis, I think it's worth stopping, going one step back and think about knots. And this is a practical knot book from the 40s. And at the time, nobody knew why knots worked. And here on the right, you see a lot of knots surgeons use today. This is actually Charles Mayo's preferred knot. And also, they knew very well, this is the Granny's knot, which doesn't work. And Ashley put it this way: a knot is either exactly right or it's hopelessly wrong. And if you make a very small change, it's either something exciting and new, or it's completely a disaster. And it took a long time later to understand why knots work. And to sum it up, it's about morphing, it's about friction, and about the number of intersections of the thread. Now, this American president obviously observed already that very small leaks, in our case in GI anastomosis, can sink big ships. And Horsted observed the criteria which are important for the perfect outcome. And you can see them listed here. And so if that's the case, and we all do that, why are we talking about failing anastomosis? And the reason is, and I'm not going into that because you all know that, and I know that in this particular institution there's been a lot of research about anastomosis. The first paper I could find actually was from Dr. Mastbohm and Henriks in '91 about sutureless anastomosis in rats. And I think the main point I want to make here is that if you look at this graph, this is the decrease of the area because of the lysis of old collagen. That's the increasing strength by newly built collagen. And so there is an area in time after about 3 to 4 days where the actual strength is diminished, and this is why you need mechanical support. Now, obviously, surgeons are craftsmen or craftswomen, so a lot of focus has gone in the last decades into technical factors, and you see them all listed here, and a lot of things are known, and you would expect that with that increased knowledge, the problem has diminished, yet it hasn't. Unfortunately, this is colorectal anastomosis, not specified between colon and rectum, but it's no big deal between the time when stapling was invented and nowadays. And if to try and put it in another way, with designing new techniques, we try to build this perfect mousetrap. Now, the question then is, what's bad about sutures and staples? Obviously, you see the elements here. There's foreign body reaction, depending on the material you use. There's pressure necrosis if the tissue doesn't hold your perceived ideal pressure. There's a lot of bacterial load, and we just start to understand that the bacterial ecology may be important in why some seemingly perfect anastomosis leak, and there's fibrosis, which may lead to stricture and certainly leads to poor function. Now, obviously, the ideal anastomosis then would have a very wide lumen. There would be no foreign body remaining, no pressure at the wound edges, no bacterial load, and no bleeding from the anastomosis, and at least theoretically, compression anastomosis serves all of those aims. Now, this is not a new concept. It originated in the early 19th century. Clinically, there was a Murphy button, which was used for about 20 years as the preferred technique. And then there was a lot of time in between before a mechanical type Russian invention was used clinically, and also the Valtrak system. And now there's some new incarnations of the same principle. And the question is, why didn't that take on? Because if you look at the Valtrak, there's level 1 evidence that it's the same results in terms of outcome as compared to staplers. And yet the system was not successful in what we could call the marketplace. Now, obviously, this has to do not only with marketing, but also with limitations that were in that system. The problem is that there was a fixed distance, but not fixed pressure inside the space between the rings. It was only usable in open surgery, only with end-to-end anastomosis. And the main criticism was that the luminal passage area was quite small as long as the device was in place. And there were specific problems with the various technologies. Now, this is the new thing, which is called the colon ring, because that refers to the actual device that's doing the anastomosis. And we use an apparatus which is quite similar and works similar to a normal stapling device. I think it's worth knowing what nitinol actually is. It's an alloy. It's a unique material, and there's no other material that has those three characteristics. It's shape memory, it's super elasticity, which means that I'll show you a force strain graph later on, and there's what we call constancy of stresses. And you see that here, if you cool the nitinol down, and that's how it's used in stents, you will have a fairly stable pressure between 1% and 6% deformation. And that's when it gets warmed up again, it's quite similar. And if you look at steel, you have a very high increase in stress when you deform it, and then it breaks. Now, when we do a nitinol compression anastomosis, we can rely on previous knowledge from stapling. The device actually uses 3 springs, and it's set for slow necrosis of the tissue in between, and so late ring expulsion. And because of the nitinol properties, the pressure will be the same whether the system has this distance or this one here. So asymmetrical anastomosis is possible. And you can see a model on this slide. Now, this fulfills at least some of these criteria. As I said, you will get an immediately water and airtight anastomosis. There's virtually never bleeding, and in the more than 10,000 cases done worldwide, not a single case of bleeding has been observed. There will be no foreign body because the ring is expelled when it gets loose. And the other thing is the external ring diameter actually equals the width of the final anastomosis, and so this is actually the widest lumen mechanical anastomosis currently available. And if you look at that, this last drawback of the small passage has been dealt with because the ring has 18.2 millimeter diameter when it's in place, which equals to 28 CEA. And when it's gone, it's 27 millimeters anastomotic width. Looking at the studies that have been done, that's animal data from Mariana Burho from Cleveland in Florida. You see on the upper panel compression and the lower stapling device. You can see there's a lot less reaction, better organization, and in the late stages, it's hard to find the place of the anastomosis altogether. Now, in studies, this has been quantified, and also the interesting thing is that in the very early phase, the failure pressure actually is a lot higher than in stapling, and later on, it's equal to the other constructions. You can see the difference. This is the nitinol anastomosis, and that's stapling of a pouch, and that's after 6 and 10 weeks in a diverted patient, and this is after 6 and 10 months. And the interesting thing is that even with long-time diversion, there will not be a stricture. That's a sum up of the more relevant data that are out. There's registry data with low leak rate, especially in low anastomosis. This is a prospective phase 4 trial I've been involved with, and there was a 4% leak rate for anastomosis less than 12 centimeters from the anal verge. And this is a 4-center study in the States with similar clinical results. if you take literature from the last 10 years of anastomosis below 12 centimeters, sorry, you will get, this is stapling, a global leak rate in the order of about 14 to 16%, and this is the published literature from the compression device. We've, from the start, done a prospective audit of all our cases, and I actually switched from stapling, which I knew quite well, to exclusive compression use. And this is the first consecutive cases. Our first leak was, I think, case 72. And we scoped them. There were very few problems with anastomotic stricture. We did a sort of comparison of the, although there's weak evidence, obviously, but it's the best that's around there, stapling until 2008 in rectal cancer, and looking only at the very, very low anastomosis of less than 6 centimeters from the anal verge. There's 96 patients here, and a little bit more than half were stapling, and the rest was compression. Obviously, it's small numbers, and so there's not a statistically significant difference, but there's a difference. And that's my whole experience. That's 220 patients up to October, and you can see it's still the same. Anastomosis less than 6 centimeters, a little bit less than 6% leak rate, 4% up to 12 centimeters. So altogether it's 5% in the highest risk anastomosis. No bleeding and no stricture in diversion, and only a minimal number of stricture in patients without diversion. So for me to sum it up, I think it's fair to say from the evidence we have that initial bursting pressures are higher than in stable anastomosis, which is a good thing. In the first phase where the anastomosis gets weak, the definitive strength of the anastomosis is the same as compared to stapled and hand-sewn anastomosis. There will be no problem with hemorrhage. There is less bacterial contamination because of the almost complete separation of the lumen from the anastomosis. You get the biggest anastomotic diameter, and we hope that this will translate into better function, but these studies are in the beginning. There's a very low leak rate compared to the conventional techniques, and there's a minimal stricture rate. And I hope that in future we'll only see those kind of anastomoses. Thank you very much for your attention.